with thorax, back, and cardio anatomy. So we'll try to go through some questions as well with Nisangi. And if you guys have any questions, please feel free to either let us know in the chat, or I'm sure you can message Nisangi later, and she'll be more than happy to answer any questions. So yeah, and this would be the second last lecture, with the second one being today from 3 to 4. So stay tuned for that. And okay.
All right, so cardioanatomy, back and thorax, and Karan said, just message me if you have any questions, or message in Zoom. Okay, so this is a mark breakdown of just some mostly anatomy that we're going to get in that you're going to get in your exams. You can see that anatomy people don't do awfully well, but clin skills they tend to do all right. So this is the content that I'm going to cover today: anatomy, embryology, thorax anatomy, and back anatomy. And I'm just going to whiz through some of it and just take a look at the slides in your own time as well. So anatomy of the heart. This is what the heart looks like. You should already know what this looks like. And this is just a more detailed diagram. So it's useful to think of the heart as not one pump, but sort of two separate pumps. So each side of the heart has veins going into an atrium and arteries leaving the ventricle. And the left side has thicker walls than the right side because of the greater pressure. The fibrous skeleton is what keeps the heart together, I guess. So it's useful for electrical insulation. It's a good anchor for muscle, and it gives structural support to the heart. So the first question I've got is, which of the following drains into the right atrium? Yep. So, and which of the following does not drain into the right atrium? And there's more than one answer.
B.
Yep, B. And the other one can sometimes into a small drain, but that's less important. So got H, the right border, the left border, the right ventricle, left atrium is more posterior, and the left ventricle is the left border apex. This is a little bit more detailed. You've got the right atrium with the pectoral muscle and the crista terminalis. And you can see that in the diagram. I'm not going to go into details, just a bit of anatomy. Then you've got the atrioventricular valves, and that's between the atria and ventricles. Which are the heartstrings. You can think of them, and they like that, and you can, and what they do is they prevent prolapse. You've got the tricuspid valve on the right side, and that's got 3 cusps, and the mitral valve on the left with 2 cusps. With the embryology of the heart valves, we'll see the first cusp is and then that is what separates into the aorta and the pulmonary trunk. And why this is sort of important is that the names of the cusps relate to how they were embryologically rather than how it ended up as an adult, because of the way that they twist. Question 3, a 58-year-old man visits the GP complaining of lightheadedness. The GP listens to the mitral valve by placing the stethoscope in the second intercostal space on the left side in the midclavicular line, on the fifth intercostal space in the midclavicular line, or in the fifth intercostal space next to the sternum, or the ear over the chest. Okay, so it's the left fifth intercostal space in the midclavicular line. And Ovale, can you remember where all the different valves are is all prostitutes take money, and you can see just on the diagram got aortic, the second costal space on the right side, and then pulmonary, tricuspid, and mitral. Something that's wrong with the valves is stenosis and regurgitation. Next question, which valve is the most likely affected by infective endocarditis? The answer is the tricuspid.
Sorry, but just with the infective endocarditis, I know a few first years asked this question earlier. Could you explain why this is the case?
I think it's because endocarditis, you can get that from the blood, from say injecting IV. So then the blood first goes in to the right side of the heart, and the tricuspid valve is the first valve that it encounters.
Absolutely.
So this is a little diagram that I drew of stenosis and regurgitation. This is more useful for in skills stuff, and it's just where, so you've got systole and split into systole and diastole, and you can see that in stenosis there's for aortic and pulmonary you get stenosis in systole and regurgitation in diastole, and for the tricuspid and mitral you have regurgitation in systole and stenosis in diastole, and this might be a useful diagram for you to draw out just to be less confused about where systole and diastole, which heart murmurs you get where and when. Sorry. Question 5. What's the name of this branch of the aorta? It's the first branch coming off the arch of the aorta, and that's the brachiocephalic trunk. And a way to remember that is the branches of the aorta is the ABCs. So you have the ascending aorta, brachiocephalic trunk, common carotid, and the left subclavian artery. And you've also got the arteriosus, which isn't really a branch, but that's just after the 3 main branches. Question 6. Which of the following is true about the coronary vessels? Okay. Is the coronary vessels fill in diastole, and they arise at the aortic sinuses of the ascending aorta. So this diagram kind of shows that because the coronary vessels originate just under the cusps of the aortic, just under the aortic cusps of the aortic valve, it means that when you're in systole and in systole the opening to the coronary vessels are closed, and it's in diastole when there's no blood going through that the coronary vessels actually fill. Next question. Which artery supplies the anterosuperior 2/3 of the interventricular septum? Okay, so that's the left anterior descending. And the widowmaker artery refers to which artery? It's the anterior descending artery. And another question, which is the matching pair of coronary arteries and veins? It's the left circumflex artery and the great cardiac vein. So an explanation of that one is in this table, each of the arteries correspond to the veins. Here, so the left, you can sort of remember that with like that artery is like the big artery that you learn about, and that's the great cardiac vein. And I guess it's something that you just have to remember. And I'll move on to the pericardium. So there are 3 layers. There's 2 main layers, the fibrous pericardium, which is continuous with the central tendon of the diaphragm, and that works to anchor the heart to the surrounding, and the serous pericardium, which is divided into 2 layers. You've got the parietal layer and the visceral layer. The parietal layer is, and same with the fibrous pericardium, they're both innervated by the phrenic nerve, and the visceral layer is the same as the epicardium, which is the outer layer of the heart, and that's by the vagus nerve. So pericarditis and cardiac tamponade. Pericarditis is inflammation of the pericardium, and that's when you get symptoms like friction and pericardial effusions. And cardiac tamponade is when this causes compression of the heart. The pericardial sinuses is this picture here where you can sort of put your finger through, and it's useful for clamping in surgery. There are 2 sinuses, so the transverse pericardial sinus is the one that's important in surgery, and you have the oblique pericardial sinus, which is less important. And just a note about the word sinus, it can either mean an open or air-filled space, or it can mean a collection of vessels. So embryology of the heart. For this, so this is just what happens in each week. I think what the specific weeks are a bit not that useful to remember, but how it's is that blood from the atrium, which is at the bottom, to the ventricles, which are at the top, and that's how the blood travels when you start, and then it's the rotation that makes the heart the way that it is. And the ones in the red are the pathologies that I'll sort of mention. I won't actually go through a lot of the embryology because a lot of videos do that a bit better than I can. And so just watch the videos. But this diagram is also good because you can sort of see how the heart twists so that the atria end up at the top and the ventricles at the bottom. It starts with the endocardial cushion and the septum primum, and then it creates the first hole, which is the foramen primum, and the foramen primum reaches the endocardial cushion, which closes off the ostium primum. And then you have the septum secundum and the septum primum, which create the foramen ovale, and then that comes up later on. So next question, which of the following is not a feature of fetal circulation? So the answer is the lungs have low pressure, which allows oxygenated blood to fill them and help them develop. Why that's not true is because the lungs actually have high pressure, which stops oxygenated blood going to the lungs. But going through all the true answers, the ductus arteriosus can be kept open with prostaglandins, and they do that in some pathologies, like that we'll talk about later. The foramen ovale is inferior to ostium secundum, and the ductus arteriosus allows blood from the pulmonary trunk to the aorta. This is a diagram from the lectures that just show the different shunts that used to bypass the organs and the adult structures associated. And I thought this was just a cool diagram showing the difference between the fetal and the adult circulation, showing the different shunts at the liver and the lungs. So the foramen ovale is a shunt from the right atrium to the left atrium, and that's used to bypass the lungs. The stiff septum secundum is, and the septum primum is more flappy, and that allows the blood to go from one side to the other, but not from the other low pressure side to the high pressure side. So when the baby is born, at the first breath, the lungs open, and that reduces the pressure on the right side of the heart, which means that the foramen ovale essentially closes and becomes the fossa ovalis. But it doesn't have an anatomical closure until a few days later, and in some people it never closes anatomically, and it's just the pressure balance keeping it closed. So some people, when they're in about their 40s, and the pressure, they start getting high blood pressure, and there's different pressure changes, it can actually open up, and that's called a pro-patient fossa ovalis. Another defect is atrial septal defect, which is essentially a hole in the wall between the atria. And the ostium, when the foramen secundum and foramen ovale, like the two holes overlap, and then the blood can flow from the left side to the right side. The ductus arteriosus is the duct between the pulmonary trunk and the aorta, and this becomes the ligamentum arteriosum. And a clinical note with that is, in surgery, the left recurrent laryngeal nerve can be damaged, and that leads to a hoarse voice after surgery. This is a meme, and it just shows that what different things become. I think it's funny and mildly useful. The truncus arteriosus is the embryological form of what forms the aorta and pulmonary trunk, and the diagram shows that it actually, when it separates into the aorta and pulmonary trunk, it actually, the septum is very twisty. So you can get transposition of the great vesicles. When that doesn't happen, and essentially all the oxygenated blood start going to the lungs, and the deoxygenated blood is pumped to the body. And that's when I mentioned that prostaglandins can keep the ductus arteriosus open. So prostaglandins are given so that at least a little bit of oxygenated blood can get into the systemic circulation until surgeries, until you can get them into surgery. So a question, Tetralogy of Fallot includes which of the following defects? It's pulmonary stenosis, and a way to remember all the four conditions are proved. So pulmonary stenosis, right ventricular hypertrophy overriding aorta, and ventricular septal defect, and the E is for early surgical intervention. And the arrows show which ones lead to the other, so you can sort of imagine that when you have pulmonary stenosis, it's harder for the blood to go through, to get to go out of the right ventricle, so then that leads to ventricular hypertrophy. And having ventricular septal defect means that there's an overriding aorta because the septum isn't reaching where the aorta starts. And this is just a diagram from the lectures showing where if there's is there a shunt and is there sinuses. So anatomy of the thorax, you have the ribs, costal cartilage, and sternum. The mediastinum, there's a superior, middle, posterior, and anterior. And ribs, I'll just go back. So the heart is in the middle mediastinum. The typical ribs are 3 to 9, atypical ribs 1 to 10, 11, 12. Features of typical ribs, you have the head, neck, tubercle, and body, which is not true of a typical rib. Does it have a wedge-shaped head, a tubercle that articulates with the costal facet of the transverse process of the thoracic vertebrae. The typical ribs include ribs 3 to 7, 10, and 11, and it has a costal groove containing the intercostal vein, artery, and nerve. That one because typical ribs are 3 to 9. These are the different parts of the sternum. So the joints of the thoracic wall, there's a costo-transverse process between the of a rib, transverse process of the vertebrae, and a costovertebral process. Intercostal muscles, this is important to remember. So the external intercostal muscles, the direction of the fibers, are hands in pockets. The internal intercostal muscles are hands on chest. And most intercostals, it depends where you read, but they're generally hands on chest as well. Other muscles are less important. Intercostal spaces have the vein, artery, and nerve in that order, so VAN. And a clinical point that's important to remember is that when you put a needle in, it's in between the ribs. You aim above the rib below, so you want to avoid any that you might hit intercostal nerve, and you just sacrifice the collateral branches. Superior thoracic aperture is also known as the thoracic inlet or the thoracic outlet, depending on if you look at things going into it or out of it. And a question about that, the thoracic outlet syndrome compresses which section of the brachial plexus? It's the trunk of the brachial plexus. So other structures can be compressed on the subclavian artery and the subclavian vein. What is at the sternal angle? A mnemonic to remember this is rat plants. I won't go through that. The recurrent laryngeal nerve. So it's a branch of the vagus nerve. And you should remember that the left recurrent laryngeal nerve loops under the aortic arch, right next to the ligamentum arteriosum. And this can be in surgery to the ligamentum arteriosum or in something else like an aortic arch aneurysm. And damage to that can cause a hoarse voice. Next question, which nerve supplies the diaphragm? I don't think the diaphragmatic nerve exists, and the answer is the phrenic nerve. So something important to remember about that is it's the nerve roots C3, C4, C5, because they keep the diaphragm alive. And that's why any diaphragm pain can be referred up to the shoulder tip, because they're the same nerve roots. And the right hemidiaphragm of of the diaphragm is higher due to the liver. And which structure does not pass through the aortic hiatus? It's the inferior vena cava, because that passes through the caval hiatus. So there's two different ways to remember what passes through which opening. So one way is the number of letters. So caval opening, there's 8 letters in vena cava, which is the main thing that goes through that opening. There's 10 letters in esophagus for the esophageal hiatus. So then that is at the level T10. And the aortic hiatus has 12 letters, so it passes through, so that's at the level 12. So you can do that by counting the letters, or you can think, I ate 10 eggs at 12. So the inferior vena cava, is at T8. 10 eggs is T10 is the esophagus, and at 12 is when the aorta through the diaphragm. So that's another way of doing it. So the parietal pleura and visceral pleura of the lungs. So you have somatic and autonomic innervation, and parietal pleura has the somatic innervation, which is essentially like having pain on your skin, and does like innervation of the visceral pleura. And you have moving on to the different recesses, you have the costodiaphragmatic recess, which is where you can see the sharp pointy end in a chest X-ray, and they're both potential spaces. So with recess, something that can go wrong is fluid accumulation. So that's when you get blunting of that sharp edge. Arteries of the thoracic wall. There are a fair few of them. The main ones are the thoracic aorta, which gives off the posterior intercostals, the subclavian, which gives off the internal thoracic arteries, which then give off the anterior artery, and venous drainage of the thorax. It can be useful to draw out this one, but you get the azygous vein draining into the superior vena cava, which is something else that happens at the angle of Louis. So a way to remember where the vagus and phrenic nerves are is that P is in front of V in the alphabet. Therefore, the phrenic nerve is in front of the vagus nerve. And the vagus nerve just does the parasympathetic innervation of the heart and the lungs. And again, it gives rise to the laryngeal nerve. And back anatomy is the last topic. So curvature of the spine, you have kyphosis, which is the primary curve that develops at birth, and that's what you see in the thoracic and sacral region, and lordosis, which is what you develop when you learn to walk, and scoliosis. So scoliosis is this picture, which is like when the spine kind of does that, when the spine's not straight looking from the back. And a way to remember is lordosis is you're standing like a lord, so you have like your stomach out, or you can ask yourself, is she thick or is she just suffering from lumbar lordosis? And I didn't make this meme because I would have made it thick with 2 C's. So the vertebral bodies, this is a fairly useful diagram to understand where different things are. So I know that I got quite confused with between what the pedicles were and the laminae and the articular processes. But I think it's fairly easy to see with this diagram. So what type of vertebrae is this? It's the thoracic vertebrae. Because of the heart-shaped body, it doesn't have any transverse foramen, which is something that you see in a cervical vertebrae, and it has a long spinous process. So in, say, cervical vertebrae, you've got a bifid spinous process. And these slides just go through all the different sections. So the atlas doesn't have a body, but it has a foramen for the dens of the axis, and they sort of fit together nicely like that. Got the cervical vertebrae, and then the main thing about that is the transverse foramen, and it's got the bifid spinous process. And you can feel C7 on the back of your neck, and that's called vertebral prominence because it's very prominent. Thoracic vertebrae, the important things about that is, I already mentioned that it's got a heart-shaped body, it's got costal facets, so these demifacets relate with the, and lumbar vertebrae, it's got a very short spinous process, but a very long transverse process. The intervertebral disc, I'll sort of skim through this, but you have the annulus fibrosus on the outside and the nucleus pulposus on the inside. And in terms of the vertebral foramen, that's where the spinal nerves exit. And ligaments, I won't go through the ligaments, but this diagram for anatomy, where each of the ligaments are. And a lot of the names are quite self-explanatory. So like the supraspinous ligament just goes along each of the vertebral spines. And a question, what level does the spinal cord usually end? And I think this came up in our exam last year. It's L1 to L2, and a way that someone remembers this is My Little Pony 1 and 2, is tail, the ends of the cauda equina, which is the horse's tail. Okay, another question. Future me is getting ready to do a lumbar puncture for the first time. Which surface landmark is at the level that she should put in the needle? So essentially, which level would I put in the needle so that I won't damage the spinal cord? And that's at the level of the iliac crest, which is L4, L5. And this is from last year's revision lecture, because I thought it was really useful to have the landmarks for all the different vertebrae levels. And I think the important ones to remember for upper limb is T7, is the inferior angle of the scapula. And for the back, these two are, especially L4, L5 is the iliac crest, because that's the side of a lumbar puncture, and that comes up later as well. So this context of the spinal cord, you have a spinal canal in the middle, or the brain, and meninges got the dura mater, arachnoid mater, and pia mater, and the epidural space outside of that, and then the skull bone. And something that I got confused about was the difference between the vertebral foramen and the vertebral foramen is the opening of the spinal cord in one vertebrae, whereas vertebral canal is what you get when you link all the vertebrae together, and the passage that the whole spinal cord goes through is the vertebral canal. And the next question is, in the lumbar puncture, I aim to extract CSF from which space? That's the subarachnoid space. So in the mater and the arachnoid mater, you have the subarachnoid space, and that's where you have the cerebrospinal fluid. The inferior end of the spinal cord, you have the main one to remember here is just the cauda equina. And disc herniation and prolapse, that's more often in lumbar. And this shows how that can affect the nerves that exit from this intervertebral foramen. And it generally affects the herniation will affect the nerve that goes out lower, like after the intervertebral disc. And this diagram sort of shows that nicely. Extrinsic muscles of the back, there's a few of them. And I think this is the last slide. So how many cervical nerves and vertebrae are there? And this is something that you hopefully already know. And it's 7 cervical vertebrae and 8 cervical nerves because of how there's C1 that goes over the vertebrae. Oh, because it comes up over and then it goes under, if you get what I mean. And that's the end of it.
Thanks so much, Nisangi. Do you have any kind of tips in regards to exams? Because I know for our year, I think back was something which took a lot of students by surprise as to how much of it was actually asked. Do you have any suggestions as to what's a bit more important than others, or just exam tips in general?
I think, I don't know, what I did last year was I made a swap vac, we made a swap vac schedule. Every day there was a group of us that would study the same thing separately, and then in the afternoon we'd come back and one of us would make questions on that particular topic, and that I found that really helped because you could sort of see where the gaps in your own knowledge were. But other than that, I don't really have anything else.
Yeah, no, absolutely. And a lot of the stuff you, like which in Thorax comes back in second year with your respiratory system. So if a lot of it doesn't make sense, it's fine. By the end of second year, you'd hopefully know more stuff, except some people like me who still are catching up. But no, apart from that, it should be good. Best luck for your exams. Again, if you have any questions, feel free to contact either Nisangi or myself, and we should be more than happy to redirect you to wherever need be. That's also anatomy. We'll be coming back at 3 for some cardiophysiology with Georgia.